about a 4-year-old boy who has left flank pain for 48 hours and fever, no previous history of trauma. A US exam of both kidney was performed. We could see left nephritis. After a CT was performed, on coronal and axial CT reconstruction, firstly without contrast, we could see nephrotic lithiasis with ureteropelvic junction obstruction. At arterial phase and portal phase, we could see cortical mass extending within soft tissue. Maybe could be an abscess. And at excretory phase, we could see nephrography asymmetry with no excretion at left. So to summarize, left nephrohypertrophy, nephrotic lithiasis with ureteropelvic junction obstruction, cortical tissular mass extending within soft tissue, and nephrography asymmetry with no expression of the left. The diagnosis was XanthoGranulomatis Pyelonephritis. In introduction, the pediatric form is rare. It represents 16% of pediatric nephrectomy specimens. It's more common in boys, and it's more frequent on left kidney. It's an atypical form of chronic renal parenchyma infection, and it mimics features of neoplastic or inflammatory renal disease. The etiology is unclear, but disease process requires long-term renal infection and obstruction. Most commonly is associated with Proteus and E. coli infection. Pseudomonas also implicated. Sometimes nephrolithiasis or congenital factors could be implicated, or individual factors. Pathologically, it's a mass of yellow tissue with necrosis and hemorrhage. The pathognomonic microscopic feature is a lipid-laden foamy macrophage with both chronic and acute phase inflammatory cells, and sometimes a focal abscess may be observed. The clinical presentation is variable. Symptoms could be included anorexia, fever, weight loss, or flank pain, and sometimes fistulization, which is a rare and dilated complication. On imaging, renal US exam show an enlarged kidney with multiple hypoechoic masses, irregular synod parenchyma, or a dilated collecting system with or without nephrolithiasis. The CT is the most useful radiographic technique to assess this diagnosis. The common findings are hydronephrosis or pyelonephrosis, kidney atrophy, stones, or fistulization. It's another example. We can see an important dilated collecting system with nephrolithiasis and atrophy kidney. What about MRI? It could be used for differential diagnosis or to appreciate extension. An important point concerns the differential diagnosis, which is renal cell carcinoma, and it couldn't be distinguishable from XanthoGranulomatis pyelonephritis, and the diagnosis is often histological. it's an example of renal cell carcinoma, and on imaging we could assess the diagnosis. Another differential diagnosis could be the renal abscess. The treatment of this affection is a radical nephrectomy. Sometimes preoperative antibiotherapy and abscess drainage could be realized, and the evolution is excellent after nephrectomy with a low risk of recurrence. So to conclude, the key points: XanthoGranulomatis pyelonephritis is a rare disease in pediatric population. The clinical presentation is variable. We have to keep in mind the aspect on imaging which mimic pseudotumoral mass, and think one differential diagnosis, which is a renal cell carcinoma, and the treatment is radical nephrectomy.